New, potentially targetable molecular alterations have been identified in several types of tumors, and pan-tumor approaches signal an important new paradigm in the clinical management of various cancers. Keep listening to hear the latest developments in tumor-agnostic treatments. Thanks for listening to this podcast from Core2Ed Independent Medical Education. This episode is supported by an independent educational grant from Bayer. So today's topic is all about tumor-agnostic treatments. I'm honored to introduce to you to two experts in the field of precision oncology, Professor David Hong, medical oncologist, and Dr. Tracy Stockley, pathologist and geneticist. We're very excited to listen to your discussion.
Well, hello. Welcome to this podcast. We'll be discussing tumor-agnostic therapies. I'm Dave Hong. I'm a professor and deputy chair in the Department of Investigational Cancer Therapeutics here at MD Anderson Cancer Center in Houston, Texas. And today I'm joined by my colleague, Dr. Tracy Stockley. Thank you for joining me, Tracy. Could you introduce yourself to the listeners?
Thanks, David. It's great to be here. So I'm a molecular geneticist in the lab medicine program at Princess Margaret Cancer Center in Toronto and a professor at the University of Toronto. So in my day-to-day work, I oversee the genomic lab testing for oncology and work closely with our pathologists and clinicians in caring for our cancer patients.
So let's start by making sure we're all on the same page. Tracy, could you explain to me what we mean by tumor-agnostic treatments for cancer, and how are they different from other kind of targeted therapies?
Sure, David. So as you know, for some time we've had access to drug treatments that are based on specific biomarkers and specific tumor types. So for example, we routinely test for EGFR mutations in non-small cell lung cancer that directs a specific therapy. But tumor-agnostic treatment is an outcome of more recent research where drug treatments are found to be effective in multiple tumor types that harbor one specific biomarker. So these treatments really are effective in many tissues with that biomarker, not just one tumor type. An important point about this is typically these biomarkers are at different frequencies in different tumor tissues, so more common in some and more rare in the others. But the benefit is once you find this biomarker, any of those tumors can be targeted by the tumor-agnostic treatment. So it's really moving us into a more genomically informed treatment using new targets regardless of the tumor origin. Just to give a little more detail, these treatments typically have the following criteria. The tumors are enriched for one or more molecular alterations, and these changes predict a response to therapy. As I mentioned, they're found across a variety of cancer types and not just one cancer type. And it really then does have a biomarker-driven targeted therapy rather than a histology-driven one. And I think finally another important point is not all tumors respond equally well to these tumor-agnostic treatments, so there is some variability.
Thanks, Tracy. And I think these tumor-agnostic treatment target multiple tumor types. And I think the development and the design of these trials differ from traditional anti-cancer therapy trials. I've run a number of these trials, and they're somewhat different, obviously, than traditional phase 2 trials where you are focused on one specific tumor type. They're oftentimes what are called basket studies, where the trial allows for the drug to be tested in a number of different tumor types. And they may not necessarily be the more common tumor types. They may be rare tumor types that harbor the specific mutation or genomic alteration. There are other kind of interesting protocol designs where you may have like a master protocol or something called an umbrella or platform design where you can eventually plug in additional tumor types or maybe even combinations of that specific drug or drugs that could then target that alteration. Tracy, can you tell us which tumor-agnostic treatments are currently approved and for which targets, and also which tumor carry these gene alterations?
Yeah, sure. I'm happy to give an overview. So far, there's several treatments that have FDA approval for tissue-agnostic therapies. The most common maybe of which is the larotrectinib and entrectinib for tumors with the NTRK gene mutations. And for tumors that have demonstrated deficient mismatch repair status or are microsatellite instability high or of high mutation tumor burden, there's pembrolizumab. And there's also dostarlimab for tumors that have mismatch repair deficiency. Now, thinking about tumors that might carry other mutations like the BRAF mutation V600E, there's dabrafenib and trametinib. And finally, selpercatinib for tumors that have RET-G mutations. And so as we talked about, we see these alterations across various tumor types, and that really allows us to expand the use in the lab to test for these and then hopefully expand use of these therapies. Another example then might be RET mutations that are found in multiple tissues, including thyroid, lung, breast, skin, and colon. And similarly for NTRK, these are found in many different cancer types, including breast, salivary, thyroid, lung, soft tissue, skin, colon, and more. And again, as we discussed, a key thing to remember is the likelihood of finding these tumor agnostic biomarkers really does vary between different tumor types. So some are much more common and some are very rare. So it really is the molecular testing that you need to have access to in order to identify these patients who might benefit from therapy. So now let me ask you a question, David. As a medical oncologist, you've had firsthand experience using these therapies in your patients. So what sort of response would you expect to see with these therapies, and are the effects similar irrespective of the tumor histologies?
Yeah, it's a really good question. Most of the patients that I've treated on these tumor agnostic therapies really have been in the context of clinical trials. And some of the drugs that I've helped develop have eventually developed a tumor agnostic indication. But I often tell other physicians who ask me about tumor agnostic that if in some instances, if you find these alterations, and they can be relatively rare, such as NTRK, it's almost kind of like a lottery ticket to some of these patients who have metastatic, chemo-refractory cancer. I mean, the data that we have now on over 200 some patients with larotrectinib, the response rates are well above 70%. Some of these patients go into complete response. I still have a patient close to 9 years who's still on from the phase 1 trial. And so the responses can be dramatic. And I think other physicians will tell you other targeted agents, whether it's selpercatinib with RET, in some instances, for example, in MSI high tumors with pembro or TMB high, these responses and duration of response, probably more importantly, can be profound. So, I really encourage physicians and also, patients, if they really run out of options, to try to explore if they haven't already obtained an NGS of some sort and next-gen sequencing of their tumor, to try to do that in the event that they could have one of these alterations.
Yeah, I think that's such a great point. And I think, again, from the lab side, we know some of these are very rare, but just as you say, the response can be so phenomenal that, there really is a huge benefit to being able to provide this testing. So another question, so should we give tumor agnostic therapy to any patient who might have this relevant biomarker? So are these therapies relevant in all situations?
That's also a really good question. I think as we've expanded the number of tumor agnostic indications and the number of patients on it, we're understanding kind of the nuances, I think, of these therapies. For example, although BRAF or MEK plus BRAF inhibition in BRAF V600E tumors can be profoundly effective, there are subsets of tumors that do not relatively respond to just BRAF inhibition alone. For example, colorectal cancer patients, which is a significant number of BRAF V600E patients. The chances of them responding and having clinical benefit from BRAF inhibition is around single digits. With that said, we now understand that if you combine it with cetuximab, an EGFR antibody, you can increase that response. And in fact, there is now encorafenib plus cetuximab is, for example, approved. There are NCCN guidelines that suggest that there's a trial that I helped develop and run, which was irinotecan, vemurafenib, and cetuximab. These all have significant clinical benefit, not just response rates, but overall survival benefit in these patients. But again, it is nuanced. Even with larotrectinib, it's interesting. We've now known over a period of time, as we've enrolled different tumor types, that there are some differential response rates. And if you take the whole pool of patients, it's like around 70% response. But there are subsets of tumors that tend to have lower response rates. For example, primary CNS disease, right? We know that these drugs can cross the blood-brain barrier, but in GBM, adult GBM, the response rates still hover around 30% relative to 70% in other tumor types, or even higher in other tumor types, right? So why is that? It's not entirely clear, but 30% durable response rates in CNS patients, in primary CNS glioblastoma patients, is far better than what we currently standard of care have, right? So it's still worth, I think, pursuing these patients and pursuing that subset of patients. Let me step back here a little bit, Tracy, and talk a little bit about tissue agnostic precision therapy in general. So the beauty of tissue agnostic precision oncology is its ability to treat cancers with relatively low incidence rates that have been less frequently studied or profiled. But there are obviously challenges with tumor agnostic development as well. And as a pathologist, right, can you tell us about some of the challenges from a pathology perspective, histology, tumor perspective?
Mm-hmm. Yeah, sure. Yeah, there are still certainly challenges from the lab perspective with, the tumor agnostic testing and the therapies. So we know that there's still heterogeneity of some of the drug effects in the different biomarker positive tumor types. So that's something that's been observed. Of course, there's always differences in tumor biology and the natural history of a cancer that might affect the response, and it's not always very well understood. And as we talked about before, the different mutation frequencies among the different tissue types is a challenge. And sometimes there are also inherent resistant mechanisms that can present in some of the tumor types that lead to some challenges too. And David, from your perspective as a medical oncologist trying to access tests, what are some of the challenges that you might see with the testing or the access to testing that you might need?
And so in our institution, accessing testing is not that hard, to be honest, but we kind of live in a bubble in a way. I think in the community, it's not as easy as someplace like MD Anderson. In MD Anderson, it's almost like a reflex test. If they don't have NGS, we will go ahead and just order that. And it's RNA-based NGS, which is probably a much more extensive next-gen sequencing platform than standard DNA and NGS. Even if we don't have tissue to do the NGS, we'll even get cfDNA, right? Now, in the community, I think there's been now multiple kind of analysis done that, even in a poster child of targeted therapy, such as non-small cell lung cancer, the actual rates of obtaining next-gen sequencing in that population is not where you would think that we would be given all the new targeted therapies in that space. And I think that's probably just logistically, there are a lot of issues more than the actual technology, right? We have cfDNA and we have NGS, which are all available in the community through vendors like Foundation or Guardant or et cetera, but at least here in the United States. But I'm sure there are issues that I don't fully understand, such as reimbursement issues, but also just, turnaround time even, right, of the actual test, right? If you have a very sick patient in your clinic and you need to have that turned around relatively quickly, 2 weeks may be too long, right? Or a week may be too long. I mean, it takes on average here in the institution at least 2 weeks for an NGS panel to come back to us, right? And in some instances, you just don't have the liberty to do that given the clinical condition of these patients. My hope is that ultimately, we're going to start getting NGS at all stages of cancer. I think most NGS and other testing are often done in patients who are refractory, right? Not upfront. They're refractory and they're in the metastatic setting, refractory to chemotherapy, and then they get NGS kind of as a last ditch effort. Hopefully that as therapies go into the adjuvant, neoadjuvant setting and then some, we will start, getting NGS from the get-go, even in earlier stage patients and also frontline patients with metastatic disease. And I think that will help us make some decisions sooner and quicker and faster with these patients.
Yeah, I really think that is a needed move. And David, maybe I'll just go back and just ask a little bit more about the trial design and implementation. So I guess I'm just wondering, like, what challenges you see in terms of trial design and implementation for these tumor agnostic therapies?
That's also a really good question. I've run now multiple of these kind of basket trials or kind of tumor agnostic studies. And I think that, obviously, the design of these studies, a lot of it has to do with, discussions with the FDA, right? What are the hurdles in which they can, would lead to eventually a tumor agnostic approval? And there's not one formula. I mean, if I just reviewed recently kind of the different characteristics of the tumor agnostic therapies, most of them have at least 15 different tumor types, and some of them are more common. The ones that have been approved to date have had at least a threshold of response. Whether you agree that that's necessarily the best surrogate marker or endpoint, that's what has eventually led to approval. Certain threshold of response, a certain duration of response. What's interesting on this is that there's been the companion diagnostic portion is interesting because most of the trials that have been approved have not necessarily been required to have eventually a companion diagnostic development. I think there's one situation when I think it was may have been Pembro or Nivo that had the TMB indication. There was a post-marketing requirement of developing a companion TMB diagnostic. But the vast majority is that people use non-companion diagnostics as a measure for treating these patients, which partly because it's reimbursed, right? But the challenges of these trials are multifold. One is obviously, you got to pick the right tumor type. Obviously, you want to pick, a certain number of arms. It's difficult oftentimes to do these as randomized control studies because these tumors are so rare, right? And so there's a lot of different complications of these studies. But I think the gist of it is I think you'll see more and more of these. At least in my clinic where I do mostly clinical trials, I see more and more of these trials, and the attempt to get some kind of tumor agnostic approval down the line. And I think you're going to see more and more of these indications FDA approved, and ultimately, community oncologists who are listening to this will have to learn which indications that they can treat their patients with.
Yeah, those great points. Yeah, thanks. And maybe just from the lab side, just thinking about the broader use of NGS for these tumor agnostic therapies, a real challenge is having, the right tissue and the right sources and informatics, interpretive algorithms in order to develop these tests. This may be more relevant outside of the US, where we are often making our own or using our own NGS tests in-house. And I think, again, one of the things about these tumor agnostic therapies and the rarity of some of these tumors harboring these biomarkers is you really need large collaborative studies and ring studies to bring together people to help validate the tests. And certainly for the tumor agnostic therapies, we've really seen some great work in that way to help bring people together, even internationally, to share samples and work up algorithms to enable this testing.
So when you think about 5 years out, maybe even just a couple of years out, Tracy, do you see anything in the horizon that could be other targets for tumor agnostic treatment?
Yeah, sure. So there are a few ongoing right now. So there's the Destiny pan-tumor trial that's looking at HER2-directed antibody drug conjugate trastuzumab deruxtecan that has response across multiple HER2-expressing solid tumors. So endometrial, cervical, ovarian, bladder, and biliary cancers. Another emerging one are the NRG1 fusions. And these are a potential tumor agnostic therapy in multiple tumors, and including non-small cell lung, breast, cholangiocarcinoma, ovarian, pancreatic, renal, bladder, and sarcomas.
All right. Well, thanks again, Tracy. It's really been an enjoyable discussion with you on this topic. I just want to wrap up to kind of highlight some, I think, key points that I've gotten out of this discussion. Number one, tumor agnostic therapies are here, and many of these therapies can have profound effects on your patients. So I think testing is key. Whatever testing that you have, the ability to get specifically, ideally, NGS testing. I think two, that there are going to be a lot more of these therapies in the near future, and you've just described a number of these that are coming down the pike. So, I think to ultimately help our patients and ultimately treat them with the most cutting edge therapies, we really need to be aware and conscious of these upcoming indications.
Mm-hmm. Yeah, thanks. And for me, I think it's just really gratifying to see the outcome of so much of this research and this trial work that's really bringing these tumor agnostic therapies to help patients. Thanks, David. It's great to talk to you.
All right. Thank you, Tracy. And thank you all of the listeners. And we hope you enjoyed our discussion.
Thank you so much for sharing your insights, Professor Hong and Dr. Stockley. We've learned a lot from your discussion on the latest developments in tumor agnostic treatments. If you liked this episode and want to find out more about precision oncology, then look on the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this episode, subscribe to our channel, or inform your colleagues about it. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by Precision Oncology Connect, a group of international experts working in the field of precision oncology. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the Precision Oncology Connect group. For experts' disclosures on any conflict of interest, please visit the Core2Ed website.